Hello, hello there. On students' demand to start this audio lecturing again, I have again started producing these audio slides. Uh, Tomorrow we are going to study about gout, treatment of gout. First of all, you should know what is gout. Gout is the deposition of sodium urate, that is sodium salt of uric acid at different body places, in the body, and which takes one of the three forms basically. Maybe gout manifests as acute pain in the joint, especially first metatarsophalangeal joint, initially in form of severe pain, later on other joints singly or in group may be involved, and this later phase is chronic gout. First excruciating pain in the first metatarsophalangeal joint, and later other joints may be involved, and other joints may be involved. This is usual pattern, but sometimes we can see other joints like knee, wrist, etc. presented with excruciating pain with inflammation, and if the process goes on unchecked, then it may end in the chronic gout. Other forms the gout can take is urinary tract stone, uric acid stone in the urinary tract, or it may deposit as chalky white deposit in different connective tissues of the body. Thus, there may be three forms. One is form in the joint, acute gout to chronic gout, second in the kidney, and third in the connective tissue. And later two as well as chronic gout are the chronic features, and only the sudden unexpected pain in the joint, which is often first noticed, is acute gout. It is quite paroxysmal, unpredictable. This phenomenon is known as acute gout. This is one gentleman presenting with acute gout at this first metatarsophalangeal joint. Again, the other gentleman on left foot, and these are the manifestation of chronic gout, or rather I will say these are the manifestations of chronic form of this disease. You can see in this connective tissue there are chalky white deposits if you cut it, and again in the long run the patient may develop chronic gout with deposition of sodium urate or sodium salt of uric acid crystals in the joint, and this fine powder looking substance is tophi. This is also known as tophus singular and tophi plural. So these are deposits of uric acid salts are known as tophus, and in plural tophi. So let's move forward. And plasma level of uric acid and gout are often correlated. The basic idea is that normally the plasma concentration of uric acid is 7 mg per deciliter, below 7 mg per deciliter, and if it is more than 7 mg per deciliter, then it means that it has crossed the normality level, but it is not necessary that the person gets the features of gout. Person may be normal even with 8 mg per deciliter. not to confuse you, but most of the patients, gout patients, have above 7 milligram per deciliter. This is not diagnostic, it is only supportive. Drugs we have for gout, for acute gout with the first metatarsopharyngeal joint, we have these many drugs: NSAIDs, colchicine, and corticosteroid in the order of importance. Now we treat acute gout with NSAIDs. Second choice is colchicine, and if it does not work, then we go for the corticosteroids, especially intra-articular corticosteroids injections during acute phase. The most of the time we use triamcinolone are famous for this kind of acute gout. And for chronic gout and hyperuricemia, for chronic gout we try to decrease the uric acid level, and we have two types of drugs. One is uric acid synthesis inhibitors, and another is uric acid driving out of the body in the kidney. These are known as like clearing uric acid out from the urine, known as uricose-urix drug. So we have uric acid synthesis for chronic gout, which comes with the feature of tophus or uric acid stone in the kidney. We have two kinds of drug: uric acid synthesis inhibitors that does not allow the formation of uric acid, and another one is throwing uric acid out of the body. And for now we will concentrate in these things: colchicine, allopurinol, and probenecid. Colchicine, allopurinol, and probenecid, we will focus our study on these. We will describe mechanism of action, adverse drug effects, etc. of this. A new drug is coming, that is febuxostat, so we will also study this drug in this very same way. Now, typical scenario, how it comes: middle-aged to elderly men and only post-menopausal woman came with first time experience excruciating pain with features of inflammation in the first metatarsopharyngeal joint at the middle of the night when the crystal precipitates in the joint. And the patient also described one of these things like dietary excess, trauma, surgery, excessive ethanol injection. So these are the precipitants which may decrease the solubility of the uric acid, and that's why it gets deposited in the joint. So this is talking about acute gout. And so these are other precipitants that you can study, like hypouricemic therapy. Okay, hypouricemic therapy can also do that. That process is quite a bit complex, but what happens is hypouricemic therapy decreases the uric acid, and the solubility pattern of the uric acid changes. Its equilibrium shifts towards crystallization. So when we start the hypouricemic therapy, there might be chances of having acute gout. So what we do is we during the initiation of hypouricemic therapy, we co-prescribe colchicine. And the other things that is written in these vignettes are tarsal joints, ankles, and knees may involve in the first attack or in the subsequent attack. On the long run, the patient may present with one of the chronic features if untreated on the long run. Management principle: in our setup, we directly treat based on the clinical symptoms. We directly treat the patient, but what is needed is we have to demonstrate these needle separates, that is understandable, negatively birefringent. That means the crystal itself doesn't glow and the surrounding glows. Uric acid stone, negatively birefringent uric acid stone, has to be demonstrated under polarized light in the involved synovium or the tophi. You have to take the sample from synovium or the tophi, and then you have to see it under the polarized microscope. And if you can appreciate this needle shaped negatively birefringent uric acid crystals, then only you can say it is gout. Otherwise you cannot say it is gout for sure. You can guess, you can do the empirical therapy empirical provisional diagnosis, but the 100% diagnosis is only done by this thing. This is the negatively birefringent. This must be the negatively birefringent needle shaped sodium urate crystals in the sample extracted from synovium. Now, acute gout. Acute episode has to be treated with ice packs and rest symptomatic treatment or non-pharmacological treatment. And we these days use indomethacin, which is NSAIDs, is one of the NSAIDs, and it is 90% efficacious. 90 out of 100 people will be, with their first attack, will be cured by this drug alone, that is indomethacin, and its dose is we give this drug 50 mg 3 times a day for 2 days, and then afterwards we give 25 mg per oral 3 times a day for up to 7 days. So this is the drug of choice is these days is indomethacin. If your one of the relatives has this, then you can start indomethacin at once, and if the most probably the symptoms will be cured. And NSAIDs, all NSAIDs can be used. Indomethacin is one of the best, and except aspirin at dose less than 2.6 gram per day, because at this dose it causes uric acid retention. And colchicine was the best drug, but it is favored less these days due to its side effect, severe side effect. It causes severe diarrhea, colchicine. That's why it is not used these days as the first line. And steroid, as I mentioned you earlier, intra-articular in refractory cases, and the triamcinolone is the one which the vial you can get in the pharmaceuticals, and then you can try this. If it is refractory, not treated by NSAIDs and colchicine, it is third line. You can say it is third line in this steroid. And now hypouricemic therapy. When to initiate hypouricemic therapy? When you have more than 2 acute episodes. When you have more than 2 acute episodes, or you have the presence of tophi that you saw in the diagram, like ear tophi and tophi in the small joints of feet. If you see one of these and demonstrate it, then you can start hypouricemic therapy. And aim is to cause uric acid below 6 milligram per deciliter. And the one thing you have to remember is that during hypouricemic therapy, when you patient have acute fever and you start hypouricemic therapy, or just you if you start a hypouricemic therapy, there is chances that the equilibrium of solution of uric acid shifts towards more crystallization. That's why it may crystallize in the joint and causing the acute symptoms. So while starting hypouricemic therapy, you have to give low dose colchicine, and along with the hypouricemic therapy, till the patient become normouricemic, and or the patient and normouricemic, that is below 6, and if the patient has no attack for 6 months, and those tophi these gets cured, or these get dissolved, and they go away when you start the drug for hypouricemic therapy for quite some time. Now, non-pharmacological aspect of hypouricemic therapy, as you all know, body weight, food high in purines has to be resisted, ethanol use has to be limited, especially beer, liquid intake has to be increased, fructose containing foods, that is Coca-Cola and all that, and beverages should be, and diuretics like thiazides, furosemide also causes uric acid, excessive uric acid, so these has to be avoided. Now, food rich in purine, that will be asked by your relatives. So these are the ways to meat and meat extracts, yeast including mushroom, alcoholic beverage especially beer, and legumes like gedagudi, like beans, peas, lentils, these are legumes, cauliflower, oatmeal, asparagus, spinach and oatmeal. These has to be decreased intake. The patient should take these kinds of food less to decrease the uric acid in his blood. Now, hypouricemic drugs, we have uric acid synthesis inhibition therapy. When the when in 24 hours the person secretes more than 800 mg of uric acid in 24 hour, then these are known as overproducers. If you measure the urine of the patient for 24 hours and examine the uric acid in that urine, and in 24 hours he produces more than 800 milligram, then it is known as overproducers. So synthesis inhibitors are basically for the overproducers, allopurinol and febuxostat. And uricosuric drugs like probenecid and sulfenpyrazone, these are for those whose uric acid is less than 600 mg per day, that is, they have less uric acid in the blood. They have less uric acid in the blood, or sorry, they are throwing less uric acid in the urine in spite of high blood uric acid level. So it means they are under secretor, or they are secreting less amount of uric acid in the urine. So what you do is, if they have good renal function, you will start with probenecid and sulfenpyrazone. Now, drugs for acute gout, we have NSAIDs, colchicine and corticosteroid. Colchicine is new for you, so we will talk about this. Colchicine, it is derived from alkaloid. I will not go into detail. Mechanism of action, okay, it is Colchicum autumnale. The name of the plant from which this alkaloid is derived is Colchicum autumnale. Mechanism of action, this is important. Microtubules are essential for migration and phagocytosis by leukocytes. Microtubules are important for migration and phagocytosis by leukocytes, and this phagocytosis and leukocytes are responsible for producing inflammation in the gout joint. So what this colchicine do is, it binds to the fibrillary protein, that is intracellular fibrillary protein, and prevents its polymerization into the microtubules. Colchicine binds to fibrillary protein, and these fibrillary protein are prevented from polymerization into the microtubules. So no microtubules means no leukocyte migration, phagocytosis. This is the way in which it acts. Once again, microtubules are essential for leukocytes to migrate and phagocytose in the inflamed joint, and these colchicine bind to the fibrillary protein and prevents the microtubules and prevents the polymerization into microtubules. Thus, no microtubules means no leukocyte migration and phagocytosis. Besides, it also inhibits the leukotriene B4, which is one of the pro-inflammatory cytokine. Thus, we see it does not alter urate metabolism and does not have analgesic property, but by preventing the formation of microtubules from fibrillary protein, it prevents the migration and phagocytosis of leukocytes. That's why it is used. So what are its uses? Uses is, in gout it is dramatic and often diagnostic response and use, but their use has been subsided by NSAIDs, indomethacin particularly. And as I told you earlier, while initiation of the hypouricemic therapy also, you have to use prophylactic overlap treatment. You have to use colchicine for some time. And besides, since it causes metaphase arrest, it was tried in cancer chemotherapy without much success. And hepatic cirrhosis, it is used in hepatic cirrhosis, and Katzong has also written that it is used in acute Mediterranean fever and sarcoid arthritis, which I am not much aware what they are, but it has been tried and used in hepatic cirrhosis. In detail, I am sorry, I don't know. Hepatic cirrhosis, it is used in, it may be used in hepatic cirrhosis. These are from books. So ADR is GI toxicity nausea, vomiting that you can easily say, and it may cause watery diarrhea to bloody diarrhea. Watery diarrhea by neural mechanisms, and bloody diarrhea because it inhibits mitosis in the rapid turnover mucosa, because it inhibits mitosis by binding to the fibrillary protein and inhibiting the formation of microtubules by polymerization. So it may cause bloody diarrhea as well as watery diarrhea. And besides, in overdose, if lots of colchicine is taken by a person, it may cause acute muscular paralysis with respiratory failure, and in long run, if it is taken for a long time, rather I will call it toxicity. Toxicity, that is toxicity may be two kinds. One is acute, another is chronic. Taken for a long run, it may cause hematological adverse drug reactions like aplastic anemia and granulocytosis. So altogether we have one, GI toxicity like nausea, vomiting, all that, and another is bloody diarrhea because it causes arrest of mitosis, therefore bad for the cells having high turnover. Turnover means they are rapidly forming ones. So, and bloody diarrhea as well as this watery diarrhea, and besides they are danger. Their toxicity is in acute overdose. It may cause respiratory paralysis due to muscle paralysis, and another is it may cause hematological side effects, that is aplastic anemia and agranulocytosis. Therefore, there are 4 side effects. Now, interaction: colchicine inhibits CYP3A4 and therefore retard the colchicine metabolism. Inhibitors of CYP3A4 inhibitors, just like cimetidine, azoles, just like other drugs like erythromycin, etc. So they retard the colchicine metabolism by decreasing its hepatic metabolism through CYP3A4. It is a general concept, so it also applies to this drug colchicine. Contraindication and precaution of colchicine: this as intravenous colchicine has been discontinued. The contraindication: intravenous colchicine is discontinued because of its adverse effect. Now we can go for the allopurinol. To understand allopurinol, you have to understand this diagram from K.D. Tripathi. This is allopurinol. This is allopurinol with double ring structure. One has hexane ring and another have azole ring, and this double ring structure is similar to thiamine. This is similar to thymidine and cytidine. These are not cytidine, these are purines. This is structurally, it is purine, that is adenine and thymidine. These are purines. So these are purines, and so are the hypoxanthines and xanthines. They have also the similar structure, double ring structure. And so what happens is, this allopurinol, when goes to the body, this allopurinol has capacity, will inhibit xanthine oxidase slightly, only very less. It inhibits the xanthine oxidase, and it is acted upon by the xanthine oxidase, and it converts from allopurinol to alloxanthine. allopurinol to alloxanthine, and this resultant alloxanthine is strong inhibitor of xanthine oxidase. So allopurinol causes is activated by the xanthine oxidase, and it inhibits the same xanthine oxidase. It also inhibits allopurinol, but more amount is inhibited by alloxanthine, which was converted by xanthine oxidase. And this xanthine oxidase is normally responsible for conversion of hypoxanthine, which is the end product of purine metabolism, that is coming from purine metabolism, and this hypoxanthine is converted into the xanthine by xanthine oxidase, and again the xanthine is converted into uric acid by xanthine oxidase, and therefore this xanthine oxidase is inhibited. So what may be the result? Result is that amount of uric acid decreases a lot, and amount of xanthine also decrease, and amount of hypoxanthine will increase. So what happens is, xanthine and hypoxanthine, these two, xanthine and hypoxanthine, xanthine and hypoxanthine are more soluble and have higher renal clearance than the uric acid, and each has its individual solubility. Precipitation and crystallization in tissues and urine does not occur with these xanthine and hypoxanthine. Xanthine and hypoxanthine increase, but they are soluble and was thrown away in the urine, and uric acid will form, no uric acid is formed, so no crystallization in the joint, no deposition of sodium urate at different connective tissue, so no arthritis, acute arthritis, or no chronic deposition of urate resulting in tophus. So I think I have made my point clear here. Once again, to summarize, normally the purine metabolism of the body ultimately results in hypoxanthine, and hypoxanthine converts into xanthine, and xanthine converts into uric acid, and this all is facilitated by xanthine oxidase. And what our allopurinol does is it slightly inhibits the xanthine oxidase, and itself get converted into the being purine, itself gets converted into the alloxanthine, and this alloxanthine will heavily stop xanthine oxidase from functioning to change into uric acid. Now result is that more xanthine and hypoxanthine in the blood, and these hypoxanthine and xanthine are excreted easily from the body, being water soluble. So uses of allopurinol is hyperuricemia, mainly in overproducers with tophi and nephropathy. As you can see, hyperuricemia associated with uric acid, you can say associated with tophi, with uric acid stone, etc. And secondary hyperuricemia is due to cancer chemotherapy, radiation. Cancer and radiation kills lot of cell, and cells have purine, and purine converts ultimately into the hypoxanthine, then to xanthine, then to uric acid, and this causes secondary hyperuricemia, and you stop the formation of uric acid, you halt it, the formation of uric acid. So this sounds quite good for these conditions also. And thiazides and other drugs, thiazides also causes uric acid, increased uric acid in the blood. And yes, the another very important use of allopurinol is in Kala Azar, but it has very poor efficacy, so rarely used now. But you can say that hyperuricemia, secondary hyperuricemia, and Kala Azar, these are the where it is. Allopurinol, its side effects are very uncommon. Few non-specific like gastric irritation, headache, nausea, dizziness to hypersensitivity reaction, even up to Stevens-Johnson syndrome. Few non-specific, and one is very important, hypersensitivity reaction, even up to Stevens-Johnson syndrome, which is one of the severest form of skin rashes. Interaction of allopurinol, it inhibits the degradation of 6-mercaptopurine and azathioprine. The main thing is there are two immunosuppressant drugs, azathioprine and mercaptopurine, and these drugs are also metabolized or destroyed in the body by xanthine oxidase. These drugs are also destroyed in the body by xanthine oxidase, and your drug, this xanthine oxidase inhibitor, decrease their metabolism. So when you have to use this drug, use only 1/3 of them. For example, if you are singly prescribing azathioprine as 100 mg per day, then you have to prescribe 33 mg per day, because xanthine oxidase, which destroys azathioprine, has been stopped by our xanthine oxidase inhibitor allopurinol. And similarly with probenecids, it have one-sided relationship. It prolongs the T half-life of probenecid, and probenecid shortens the T half-life of allopurinol, and allopurinol also potentiates warfarin and theophylline by inhibiting their metabolism. It basically increases all mercaptopurine, azathioprine, warfarin, theophylline. It increases, and even probenecid. It increases the amount. It increases the action of all these drugs, but itself gets slapped by this probenecid. Now, contraindications and precaution of allopurinol. Non-adherence means lack of compliance, because patient thinks that there is I can do without this drug, and almost land in problem. So you have to precaution you have to tell the patient not to withdraw and liberal fluid has to be taken along with this liberal fluid, so that you can dissolve xanthine and hypoxanthine more, and you have to take and it is contraindicated in those persons with hypersensitivity, as I mentioned you, Stevens-Johnson syndrome, and other are basics like pregnancy, lactation, kidney, liver disease, etc. Now we are heading to probenecid. Its main action is it competitively blocks the active transport of organic acid by organic acid transport protein at all sites. There are something known as organo acid transport protein, especially in the kidney tubules, and it stops this organic acid transport protein. And there is one subtype of organo acid transport protein, that is URAT1, which normally reabsorbs uric acid. So if the URAT is inhibited, then what will happen? Yes, it is inhibited, so it is not reabsorbed. So that means uric acid is secreted out from the kidney to the urine. It inhibits OATP, which normally responsible for absorption of uric acid in the kidney tubules, and this drug stops its function. Therefore, the uric acid is thrown out from the body. Uses: it has two uses. One is chronic gout and hyperuricemic condition, and another is it increases the amount of penicillin and cephalosporin, which are normally secreted out by blocking their excretion or blocking their secretion, and that's why the plasma level increases. It increases the plasma level of those things thrown out of the kidney, and it decreases the plasma level of those things which is normally reabsorbed, that is uric acid, because this OATP, organic acid transport protein, are bidirectional function. Interaction, it increases the sulfonamide. Besides penicillin, it also increases the amount of sulfonamides, methotrexate and indomethacins normally thrown out of the kidney, and it as I told you, it is present everywhere. It is present everywhere. So in the OATP is present everywhere. So in the bile, it decreases the secretion of rifampicin, and it inhibits the tubular secretion of nitrofurantoin, which is normally secreted in the urine. And because the urine has less amount of nitrofurantoin, so it cannot kill the bacteria in the urine. So that is urinary antiseptic. Nitrofurantoin's function is gone. So this is one of its reactions, one of its interaction, I suppose. And as I told you earlier, aspirin below 2.6 gram per day block its uric action of probenicid. Aspirin blocks probenicid's uric action. It's like the boss comes, he doesn't listen to this probenicid, he will kick out its function and retains uric acid. So we have, it has like cephalosporin, penicillin action with sulfonamides, methotrexate and indomethacin. In the biliary tract, it inhibits rifampicin secretion, and it inhibits the concentration of nitrofurantoin in urine and prevents its urinary antiseptic action. And in aspirin, below 2.6 gram per day, aspirin also blocks its action. Probenicid, it also causes few side effects like dyspepsia, rashes, and it may cause, when huge amount is used, it may cause convulsion and respiratory failure. Dyspepsia, rashes, and convulsions and respiratory failure in toxic dose. Contraindication and precaution of probenicid: you have to take plenty of fluids. Because it is uric. So urine, lots of uric acid are thrown in the kidney, urinary tract. So if you don't take plenty of water, it will again form uric acid stone in the urinary tract. So, and urine prison, for the same reason, you have to increase it is acid, so you have to increase the pH of, you have to make the urine alkaline with alkalizers. And besides, and in renal insufficiency, the much uric acid cannot be thrown, so it is one of the contraindication. Renal insufficiency with serum creatinine more than 2 mg per deciliter is one contraindication. The normal is below 1.4 mg per deciliter serum creatinine level, and cautiously it has to be used in peptic ulcer patient. As I told you, it causes dyspepsia. Febuxostat, it is similar to the allopurinol, but structurally it is non-purine and it causes the same xanthine oxidase inhibition. It is, however, more effective than allopurinol, more potent than allopurinol basically. Febuxostat uses, like allopurinol, everything like you go from chronic gout to hyperuricemic condition with tophi, uric acid stone, so all that. So there you decrease the formation of uric acid. It is not indicated in malignancy associated hyperuricemia. It is not indicated for the malignancy associated hyperuricemia. For the cause, I don't know. And its ADR are only two, that is diarrhea, nausea, headache, general side effect, and liver damage. Liver damage, it is very important side effect. Febuxostat, always remember liver damage. Probenicid, always remember kidney damage. And these, I mean, contraindication. So liver function test, this is the way. If any drug causes hepatic toxicity, then the better way to write in precaution is liver function needs to be monitored. And as I told you, it also inhibits the metabolism of mercaptopurine and azathioprine via xanthine oxidase. So this is one important, not contraindication, but the dose has to be reduced. That is, the precaution has to be taken. Sorry for the spelling of precaution. Lastly, I like to name two drugs. One is pegloticase, and it may be asked in the multiple choice. That's why I am telling you. The uricase in most mammals converts it into uric acid into allantoin, which is very soluble. Uricase, and uricase recombinant form is pegloticase, uricase, pegloticase, uricase, pegloticase, recombinant mammalian uricase, pegloticase, uricase, pegloticase. Okay. And ras buricase is the urate oxidase, is the recombinant version of urate oxidase. Urate oxidase, it also metabolizes uric acid to allantoin. So uricase and urate oxidase look similar, but I don't know. So, anyway, recombinant version of urate, here is R, urate ras buricase, and recombinant version of uricase is pegloticase. Urate oxidase ras buricase, urate oxidase ras buricase, and urase pegloticase. That's all for today. Thank you.